Dr. Shannon M. Clark here. I am a double board certified OBGYN and maternal fetal medicine specialist, and I want to talk about this. Scientists may have pinpointed morning sickness cause, sparking hope for potential cures. But before I talk about that article, I want to talk about this one. This is an article that I just published in the Clinical Expert series for the Green Journal on inpatient management of Hyperemesis gravidarum. If you want to read it, it is in my link in bio, free of charge. But before I get into all of that, I want to say this. We have medications that can treat nausea and vomiting of pregnancy. You do not have to wait it out. You don't have to wait until the baby's delivered and it'll go away. You don't have to suffer and have a poor quality of life. And you don't have to go through it just because it's pregnancy and it's normal. Far too many patients are untreated or undertreated, which can lead to the progression of nausea and vomiting of pregnancy, NVP, to HG. Now I'll move along. Now in that article, we just cover a lot of things, but here are just a few of the things we cover. Suggested criteria for inpatient admission for management of HG. This beautiful diagram talks about what medications are available for use for inpatient management of HG, then what to do when you transition for the patient to go home as an outpatient. Now, if you're not hospitalized, you can just bump on down to the outpatient management. Medications are pretty much the same, just given via a different route. Now back to this article. This article talks about GDF15, which is a hormone that acts on the brainstem and has already been implicated in the development of nausea and vomiting of pregnancy and Hyperemesis gravidarum, or HG. The study reported that fetal production of GDF15, as well as how sensitive the pregnant individual is to GDF15, contribute to the development of HG. Now here's the interesting part. They found that in people who are not pregnant, if they have low levels of GDF15, they are more likely to have Hyperemesis gravidarum, or HG, when they do become pregnant, as opposed to patients who have a diagnosis of beta thalassemia, which beta thalassemia is a condition known to be associated with higher levels of GDF15 at baseline. Those patients, because they have higher levels of GDF15 when they're not pregnant, have a lower likelihood of having Hyperemesis gravidarum when they get pregnant. So it seems that exposure to GDF15 prior to pregnancy plays a role. So if a patient isn't pregnant and they are exposed to higher levels when they're not pregnant, then they have a lower risk of HG in pregnancy, and vice versa. So what does that mean for potential treatment of severe nausea and vomiting of pregnancy and HG? Well, we know that in pregnancy or early pregnancy, there is an acute rise in GDF15. So if we could find a way to block that rise, it may prevent the development of severe nausea and vomiting of pregnancy and HG. Next, since we know that exposure to higher levels of GDF15 when someone is not pregnant is protective of the development of severe NVP and HG in pregnancy, exposing non-pregnant individuals to higher levels of GDF15 may prevent the development of these conditions in pregnancy. So this will kind of be like desensitizing the future pregnant individual to the effects of GDF15. So something like this would probably only be done for individuals who experienced severe NVP or HG in a prior pregnancy. Finally, we know that metformin, which is an oral hypoglycemic used to treat diabetes, we know that metformin increases the level of GDF15 in non-pregnant individuals. So we could potentially give it prophylactically to pregnant individuals to prevent the effects of GDF15. And again, this would likely be more likely to be offered to individuals who were affected in a prior pregnancy. So to sum it up, while this is very promising and it's really cool, we are far away from any therapies targeting GDF15.